Hello and welcome to the webinar Path to Freedom, What We All Must Do to End Lockdown. My name is Ahmet Keskin. I'm the Executive Director of the Australian Intercultural Society, and it gives me great pleasure to welcome you all to this conversation. I'd like to acknowledge the custodians of all the lands we're gathering on and pay our respects to elders past, present and emerging. Tonight's topic is very timely considering where we are with respect to the pandemic and the effect it's having on society. The two largest states, New South Wales and Victoria, have had COVID case numbers to contend with, but the race to get vaccinated is well underway. To hear what that means for us, we have an esteemed lineup of experts to walk us through the path forward, and to get the program underway, it's my pleasure to introduce our moderator. Dr. Leslie Cannold is a medical ethicist and social researcher with a background in women's sexual and reproductive health and mental health. She's the current chair of the Ethics in Research Committee at the Marie Stopes International in London, a community member on the Victorian Mental Health Tribunal and Forensic Leave Panel, and writes the weekly Everyday Dilemmas column for Crikey. But before I hand over to Leslie, I just want to remind everyone that they can engage in the conversation by asking questions on the chat section. And with that, I'd like to now welcome Dr. Leslie Cannold.
Thank you so much, Ahmet, now that I'm off mute. And welcome to everyone. We have been very excited about this program, which we started thinking about around a month ago. And wow, so much has changed since we started shaping our ideas about what was going to be happening tonight. So as anyone living in New South Wales and Victoria and the ACT knows, we've been in lockdown, and particularly for the majority of the country's of Australians living in the country's two most populous states, the world in which there was liberty to see our friends and go to dinner and attend work and send kids to school, go to the gym or go to yoga classes, and even play with little ones on the playground, became a world in which none of those things were possible. Why? Because of uncontrolled transmission of the Delta virus in the community and the imposition of hard lockdowns to, well, what? In the recent past, and still to this day, in Queensland, in Northern Territory and South Australia, Tasmania and WA, lockdowns have been used to eliminate community transmission of the wild Alpha and now the Delta variant of the coronavirus, and return citizens to their normal lives, liberated from the fear of contracting COVID-19. Well, not exactly liberated. We are in the midst of a global pandemic, but liberated enough for us to open up. But what is the purpose of lockdowns in New South Wales and Victoria now that our health and political figures have officially abandoned the goal of returning to zero? With transmission and death rates from the virus growing, but also the developmental and mental health costs of what for Victorians is our 217th day of lockdown since the pandemic began, the imperative of finding a way for Australians to live with COVID-19 without resort to lockdown has become the top issue on many of our minds. So that's what we're going to explore tonight. How can we get to a world without lockdowns? How will we live with COVID-19 without them? When and how will we get there? What can you do to make sure we arrive at a future where lockdowns are no longer necessary? And what can you do to help shorten the trip? Here to help us chart the road out are three eminent guests. We have, and I'm sure he is familiar to many of you, Dr. Norman Swan. Norman is a board member for the Australian Research Alliance for Children and Youth, one of the first medically qualified journalists in Australia. He is a multi-award-winning producer and broadcaster and is the presenter of The Health Report and also Coronacast. Dr. Swan's career has been highlighted by his desire to keep the Australian public informed of health developments as they happen. This allows him to combine medical expertise with investigative reporting, clear analysis, and the knowledge to report the latest research in health and medicine. We are also lucky enough tonight to have the wonderful Professor Julie Leask. Julie is a behavioural science and professor in the Susan Wakil School of Nursing and Midwifery, Faculty of Medicine and Health at the University of Sydney. She is also a visiting fellow at the National Centre for Immunisation Research and Surveillance. Julie's research focuses on vaccine uptake, communication, strengthening vaccine programs and policy. She has qualifications in nursing and midwifery, a Master of Public Health, and a PhD in Public Health. She was the overall and global category winner of the Australian Financial Review's 100 Women of Influence Awards in 2019. And last, but definitely not least, we have Professor Nick Golding. Nick is an infectious disease modeler with a focus on globally important pathogens. He developed statistical models and software to predict the distributions of human disease like malaria and occasionally other species. And very importantly, he was involved in the modeling that the government is now using to decide how we're going to manage the pandemic from now on in regard to vaccinations. Nick is particularly interested in improving these statistical models with information about population dynamics and transmission pathways so we can better anticipate how disease risk will change in response to different disease control measures, which makes him absolutely the perfect person to have tonight. So I want to start with you, Norman. I want to ask what may seem like a simple question, but in fact, I think is one that has been changing, as I said in my introduction. What are lockdowns for? It seems to me that a month ago, everyone knew the answer, which was to eliminate COVID so few got sick and died, our hospital system wasn't overwhelmed, and we could get out of lockdown. So it was kind of a win-win. But now in Sydney and Melbourne, the justification for exactly more or less the same level of harsh restrictions has changed. For instance, in Melbourne, we've moved to extreme restrictions, which we had at one point to have one last push to get to zero. Now we've got pretty much the same restrictions, even though the Premier has explicitly abandoned that goal of getting to zero.
So I think that
Yeah, go ahead. Go ahead.
So I think that if you go back 18 months to last February, March, when we closed our borders earlier than March, but it was quite clear that we had a problem on our hands. We went to lockdown in March, not actually explicitly wanting to eliminate spread. In fact, that debate emerged probably around April, May of the lockdown last year. The initial reason for the lockdown was that if we didn't go to lockdown, we could be Italy, northern Italy, where it was out of control, many thousands of cases, hospitals overburdened, and lots of people dying, people you knew dying. And what you saw evolving in the United States, where they had almost no testing, no controls, and out of control. And you saw particularly people in disadvantaged areas dying in very significant numbers, and young people dying as well, younger people dying. It wasn't just the elderly. So we went to lockdown to stop that happening and stop our hospitals being overburdened. And we succeeded. And the talk then, you might remember, was about bending the curve. You've got the epidemic curve, which Nick will talk about, no doubt. And by the way, people don't understand something called exponential growth, is that Melbourne and Sydney have both been in exponential growth. So even though the graph is going like that, you're in exponential growth. It's just that when you get to very large numbers, mathematically, it can suddenly just go like that, even though the growth rate hasn't changed at all. It's just that it's like compound interest, you add on the numbers. Anyway, in April and May last year, the debate changed because it realized we were so successful in bending the curve, we could actually get the curve right down to zero, meaning zero spread. And that's what we did nationally and did it very successfully. Now, what's happened since, so New South Wales, every state has been into hard and fast lockdowns when they've had a few cases so that you didn't go into exponential growth, even though it looked odd that they were going at 1 or 2 or 3 cases. If they got into exponential growth, it's really hard to control. So they wanted to get in before that happened and to really get it back down to zero. New South Wales did not do that in December of last year and got away with it, but it took 6 weeks to get the outbreak under control. There are a couple of other lucky episodes, but essentially by not going in hard and fast, they got into exponential growth, which was very hard to control with a new virus, highly infectious, and they could not bend the curve. But what they have done is suppress the growth and done that very successfully. So one should not think that lockdowns are useless. lockdowns are actually working. So if lockdowns, we had lockdown in New South Wales, the model, Burnett Institute showed that New South Wales would have been at 10,000 cases a day by the 1st of August. The Burnett Institute has also shown that last week, for example, if they'd not had lockdown in Victoria, there would have been 6,000 extra cases and 600 more people in hospital. So whilst they're not doing that, you haven't seen the shape of the curve if they weren't doing lockdown, because the shape of the curve starts to do that. So what we're doing now is trying to minimize the number of people in each state who get the infection and therefore get seriously ill and die in a largely unvaccinated population where there's no natural immunity. We haven't had outbreaks of COVID in the past to any significant extent, and there's probably fewer than 1% of Australians who have got natural immunity to this virus. So we're in a very precarious stage now, but we've got vaccination, and vaccination will, in New South Wales, start to bend the curve probably in about 2 weeks' time. And in Victoria, probably in 2 or 3 weeks' time, because at much lower numbers, because they're lucky they've got those lower numbers. Anyway, so what we're doing is stopping.
What do you get lockdown? You just said we get less deaths, much fewer cases. Particularly, we're protecting disadvantaged people who are particularly vulnerable to cases and bad outcomes, and to stop even more. So in other words, you're stopping it peaking in a way that overwhelms the hospital system and causes heaps and heaps of damage. So even though you're not getting back to zero,
and you're giving
the curve.
Yeah, and you're giving vaccination a good chance to work quickly.
Right. Okay, so we'll get to vaccination in a second. Before we do that, though, Julie, I wanted to ask you a little bit about. So Norman, I think, has done a great job of describing all the good reasons why we go into lockdown, and all of those things are things we value enormously, the things that he's talked about. But there are issues with lockdowns. So we know about that. I think we arguably talk about it a little bit too little. So Professor Patrick McGorry, who many people will be familiar with as an expert in mental health, he said he'd like to see Victoria's mental health case numbers listed alongside the COVID-19 cases each day, because in his view, the cost of mental health breakdowns and suicides that result from lockdown isn't being taken seriously. Do you agree? And what do you think we need to also be accounting for when we use lockdowns?
So I think lockdowns remain important, even though there are terrible consequences for mental health, for people's lives, for their financial situations, because it would be so much worse if we weren't controlling COVID well. And that would have equally worse implications, particularly for people, for economically speaking. However, any kind of public health intervention needs to sufficiently consider the human factors. So when you decide to put police on the streets of southwestern and western Sydney to control the outlier people who aren't following the law, then you need to know that that will bring its own consequences in terms of trust. If you decide that you are going to stop people from going out after 9 o'clock at night, that brings its own consequences in terms of trust. And both of those strategies I've deliberately named because they're both on the edges of effectiveness. Not a lot of good evidence for the effectiveness of the curfews, but equally effective strategies as well bring their own costs. And that's why I think public health is good. It looks at populations, particularly with the focus on disease outcomes. It's not so strong on looking at the human factors and the human outcomes and how you might mitigate those in your policy making. And so I think having that reminder of the burden of COVID every day, I'm not sure that'd be great for my mental health. It's bad enough, the news is bad enough, but it's definitely important to keep in mind and to keep the community involved in the policy making, or at least consulted in the policy formulation, so that those kinds of human impacts alongside the disease and death are also considered when you're making public health policy to control infectious diseases.
So when you say keeping the community involved, do you mean like some sort of deliberative democratic process, like actually formally consulting the community about the values that are in play here?
Yes, I do. Particularly, I think that the whole discussion about once we reach 80%, our politicians tell us, then we'll reach that magic number and everything will change. Well, it won't. We will. It is an important threshold, and Nick can talk about that more. 70% is also a meaningful threshold in our planning, but there's still going to be disease burden. And an 80% average for Australia is not 80% in every single LGA. And the communities that are going to be lower in their...
Local government area.
Yeah, sorry, local government area, so council. The communities that are going to have lower vaccination rates are the communities that are more likely to be disadvantaged. So, and in particular, there are concerns about Aboriginal and Torres Strait Islander communities where coverage is already lower. We've already delivered a gap. So there are going to be concerns about things like that. And that's why when we say everything's going to change at 80% because we've reached a certain control over hospitalizations and deaths, we will still have them. And the acceptability of that burden needs to be something that's talked about with the public and informed citizenry in a way that meaningfully brings them into the conversation and considers their perspectives as well as the politicians' perspectives on what's acceptable.
Got it. Okay, so let's talk about those numbers, those 70 and 80%, and who better to discuss that with us than Nick. So Nick, you're our modeler. What has to happen for the lockdowns in New South Wales and Victoria, and perhaps also the ACT, to end?
Well, so that was the real question that we were being asked when we were asked to produce this modelling for the Commonwealth Government and for National Cabinet. And so the we I'm talking about there often gets billed as the Doty Institute. I'm not from the Doty Institute, but I'm from Curtin University. And actually it's a team of modellers, infectious disease modellers from across Australia who are involved in this modelling. But the question really was, what level of vaccination can we get to when we can start to go without lockdowns? Because lockdowns are the second worst thing. The worst thing is the exponential growth that Julie was talking about and that we've seen in so many other countries. And you just have to look at what happened in India and the horrifying kind of levels of impact that has had. And not quite as bad, but very, very severe in the US, the UK, and other comparable nations. But lockdowns are pretty bad as well. And what we'd like is neither of those two options. And the one thing that we can drop in to replace both of them is vaccination. So if we have vaccination up to sufficiently high level, then we can go without lockdowns and we can still avoid that exponential growth. So there's been a lot of talk about this herd immunity threshold, particularly last year when we were talking about vaccination. And so the herd immunity threshold, Norman described the growth rate as compound interest, and that's exactly right. And the herd immunity threshold is how much vaccination we need before that interest goes negative. So before you go from it growing to decreasing just because of vaccination alone, that doesn't have to be absolutely everyone, but it needs to be a high proportion if you have a really fast spreading virus. And so obviously we would have liked to have got to a vaccination number that we know would on its own completely get rid of Delta and make it go extinct from Australia. But unfortunately, Delta is so much more transmissible. That's probably not going to be feasible even at 80% vaccination. But that doesn't mean it's not worth doing. It doesn't mean that it's not useful. It's incredibly useful because we can get enough vaccination that we can do away with lockdowns and have vaccination in combination with other things which are much, much less damaging and which people don't really see too much, such as our amazing contact tracers. So the question really...
Tell us a little bit more about that. So, because this is the magic number. So we're all hanging out for 80%. Well, we've been told to hang out for 70 and also 80%. What can happen at 70%? What can happen at 80%? And with what other things in place in addition to contact tracing?
Yeah, so at 70%, there probably would still be the need for some lockdowns, but they would be shorter and more targeted in areas where there's kind of high levels of transmission. but much, much less. We wouldn't need these large statewide, really hard lockdowns. We should be able to either have much shorter hard lockdowns or kind of less severe lockdowns. I don't know if anybody remembers that the light lockdowns have passed in the start of the pandemic. So at 70%, we can go a long way. So it eases things off. And at 80%, we should be able to do away with all lockdowns, but only if we keep some other things in place. So those things could be just keeping our contact tracing really, really effective. Now that's tricky if we let cases get really high, because our contact tracing teams will get stretched thin. But there are other things we can do as well. So we've had various different COVID safe plans and hygiene measures being suggested. And so people keeping to the 1.5 meter rule, keeping away from people when they're out and about, adhering to capacity restrictions, washing hands, wearing masks when they're told to, all those sorts of things, they help. And so if we keep some of those restrictions that aren't lockdowns, or if we have a really effective contact tracing, or a little bit of both, then 80%, I'm pretty confident that we can avoid those lockdowns at all, which would be a fantastic place to be.
But Nick, can I ask you a burning question, which is you've still got cases and hospitalizations and deaths. What does it buy you in terms of limiting those?
So when I'm talking about you need those things in place, that is, you can put those in place to keep the interest rate at about 0. So not growing, not going down. So if you have cases, you can keep cases at a very low level. Now getting to absolute 0, that is something that could be done in the short term, but with COVID all around the world, we have to keep our borders completely closed to be able to do that. And that would be very, very damaging, I think, for everyone. And so the idea here is that if you have enough vaccination, that it's preventing transmission and it's also preventing really severe disease outcomes for vulnerable people, then you can get COVID back down to a level where it is no worse than other diseases that we're used to. And so flu is the common number that's bandied around, and people generally think, we accept some flu deaths every year, so maybe that's the acceptable level of deaths. And it's horrible to talk about acceptable levels of deaths because nobody really wants to accept any. And I think, Julie is exactly right there, talking about having to have a discussion about what is acceptable in terms of a disease, in terms of the impacts it can have.
So this is something that the audience needs to think through, and Julie is much more of an expert in this than me, but the way we perceive risk is very different when you've got something new that you're dealing with. So we accept a background. So when people say, "Oh, go and get the vaccine," it's much safer to get the vaccine than cross the road, or they use an analogy like that. It doesn't compute with people because you don't think of those risks in the same way. So the flu is under the radar. There have only been a few hundred cases of flu this year. In 2019, there were 300,000 cases of flu, 300,000 cases of flu, and a lot of deaths. But we don't know that. We don't notice it because it's all common. And in many ways, it's not that we don't care about the deaths with flu, we just don't notice them, and it's business as usual. But as soon as somebody introduces a new risk, we become alerted and we become much more anxious about it. And I'm not criticizing that, I do too. And we perceive it differently. And it's a different challenge in terms of communicating that, which is what Julie is talking about now. And I think the thing that we as leaders in this, this is a group of leaders from different cultural backgrounds talking here, is that we've got to set expectations clear. And I don't think that the politicians have helped us in that. Is that if you look at the Doherty model at 80%, Nick's right, there's still a lot of restrictions in place. We are not going back to normal life. We are wearing masks. We are still getting tests in large numbers. We've got contact tracing, and contact tracing is at the core of this. And there are some warning signs here that contact tracing is losing the plot in both Victoria and New South Wales. And in the Doherty model, if contact tracing, if we get the cases so high and contact tracing loses it, we could get quite a significant surge of cases in December. Now, that's only a problem if we haven't got very large numbers of people immunized. And so I think as leaders, and I'd like to hear Julie on this, we've probably got to think of 90% as the number rather than 80%. And really, because I think at 80%, we think, oh, well, we can sit back and relax, we're at 80%. But in fact, we've got to drive forward for Olympic gold here, not bronze, because it's at 90% when if you get that surge, you're starting to see, and particularly with kids being immunized and pulling kids out of the equation, down to 12 years old initially, we're starting to get to large enough numbers of people that we're not going to see a huge problem in our hospitals, but we will notice it.
There's a lot
Julie,
going on here. There's a lot going on here. I just want to slow it down a little bit. So Nick, Norman's thrown out a challenge to you. Is it really 80%, or do we need to be going for 90%? I think that's been quite a large part of the discussion. And then we're going to come back and talk about kids.
Absolutely. So the 90% figure would get you close to the herd immunity threshold, which means vaccination only, and you don't need to do anything else. Actually, I think people underestimate the impact that contact tracing has had. When we're including in our modelling, we're not making assumptions about that. We're using the data and how long it takes for cases to be put into isolation. And that on its own, if you take everything out of the picture, essentially halves the rate of growth of transmission of COVID. So that's pretty substantial. That's something like a 50%, 60% vaccination rate just right there in our contact traces, and that doesn't affect us day to day.
And Nick, didn't you say to me that contact tracing becomes more effective when you stop trying to get to zero?
You can, yeah, so this is the big question, right? Because we've always been trying to get to zero, and our contact traces have been incredibly effective. But yeah, they're putting huge amounts of resources into getting every single last case. So that's starting to change now. New South Wales has changed its plans. And as Norman said, it has been more difficult for New South Wales to get their tests turned around and get their interviews done, but they've started to change up their strategy. And it's now more about just getting as many of the cases in isolation as possible, but not worrying about chasing down every single last one. So contact tracing can be really effective.
Yeah, and that means your contact tracing can remain more effective for longer, even with a higher number of cases. So Norman and Julie, I'd like to hear both of you on this issue around kids. So what we know about these
sorry, just before you go there, because I think Julie's probably got some really interesting insights on expectations and managing those expectations before we jump to that, when we get to 80%.
Well, it actually relates to kids too, because given that we'll have disease around, you'll start to see a shift in the age groups that are getting sick and hospitalised potentially. And COVID is a low risk in children. Even Delta continues to be, and Norman can probably elaborate on that. But because there'll be, because children, particularly under 12, won't have vaccination yet, there'll be a time when it feels scary to have children out there without that kind of protection. And I think because some risks are less acceptable, even if they're small, like risk to vulnerable, risks that are man-made, risks where you can find someone to blame for them. And so that, particularly with children, that's going to make the risk, I think we're just going to see a lot of community concern about risks to children, even though the benefits of them going back to school are huge. And according to my colleagues at the Murdoch Children's Research Institute, well outweigh the risks to them with COVID. So,
and Julie, my understanding is that in some ways the United States is blazing a path for us here, because they are wrestling right now with how to get children back to the classroom. And in general, there is a view, as you said, that it's higher risk for them to miss another year of school and the face-to-face contact. And they're talking about things like HEPA filters, so air filters, and just better ventilation in classrooms, windows open, doors open. Is that a conversation we're having here in Australia?
Well, my colleagues are pointing this out, Fiona Russell, Margie Danchin and others in Melbourne in particular, the need for masks, the need for a strategy in schools. And they're trying to get the interest of planners in states. And that's been a little bit of a struggle so far. So it'd be good to see more careful and thoughtful planning around that, and the risk communication with teachers. In New South Wales, we're certainly mandating vaccination for teachers. And that will be an important, well, vaccination of teachers is an important part of this strategy. But there are a raft of things that we need to be showing that we're planning and implementing in schools, good risk management plans, well-resourced with good communication, so that when they open, parents can have the highest degree of confidence that the risks are minimised. You can't shut out risk though, that's the issue. I think a lot of Australians realise that now, even more now with this pandemic than with infectious disease outbreaks in the past, where they're just totally intolerant of any risk.
Yeah. And Norman, in terms of the other ways that we're going to be managing risk, we're going to be managing risk. I haven't heard vaccination passports mentioned yet. And that seems to me to be one way that we're going to be attempting to encourage vaccination, but also manage the risk around people who won't be vaccinated. Can you talk us through that?
Yeah, but before I do, I just want to emphasize something that Julie said, which the Australian government has underplayed consistently throughout this. The 1.5 meter rule is, when you've been in the same room as somebody for a while, the 1.5 meter rule almost matters nothing. We kind of created that. Yeah, sure, it's not good to get coughed upon by somebody with COVID, but that's by and large not how you catch it. How you catch it is breathing in the same air as somebody in an indoor space. And we've suffered from poor advice at federal level about ventilation. Ventilation is clearly a huge issue, which could minimize risk if we could understand that. After the flu pandemic in 1918, in some countries, they changed the design of schools because they kind of knew that there was something going on here. And so you had classrooms that opened onto the playground rather than into corridors, high ceilings, windows that opened, and so on. So classrooms will be much safer places, particularly in an Australian summer, with the windows open, with fans on, maybe with HEPA filters if you can get them, with masks on. So for example, teachers immunized and wearing a mask, if the immunization will reduce your infection risk by about a half. So you're half as likely to actually catch the disease in the first place and pass it on. The mask reduces it by another 60 or 70%. So a teacher immunized with a mask on is a very low risk to the children. And it probably goes teacher to children more often than it goes children to children and to teacher. But children can be the origins of this. But in a well-ventilated classroom with it's not densely packed and so on, the risk is in fact much lower. And as Julie said, Delta is no more dangerous to children than any other version of the virus. And the children who are really at risk are the kids who are disabled, children who've got a lot of obesity, they've got maybe a problem, and heart and lung disease. So in the United States, while they've got intensive cares with pediatric conditions, it's very rare to have a healthy child, an otherwise healthy child, seriously ill with COVID. It tends to be kids with other complications. And the other issue here is something called cocooning, which is controversial, but anybody watching who's been a grandparent or a parent knows that you're encouraged to cocoon. Everybody around the new baby, before they develop immunity, which takes about 6 months, everybody's got to be immunized against whooping cough and so on, fully immunized, so that you're reducing the risk of bringing whooping cough into the baby. So if parents get immunized, and if you've got adolescents in the house and they get immunized, and you've got younger kids, you're kind of cocooning them a bit, because the household is where they're more likely to catch it. And so we can do all those things until we get immunization for children.
Which will
so
happen
the vaccine.
But let's go back and talk more about vaccines, because I think let's go back to just talking a little bit about vaccines for adults. I can see some of the questions coming in. So just going back to vaccines for adults. So when we talk about 80%, and I might throw this back to you, Nick, does it matter whether or not it's just a global figure, like a top figure, just 80%? Or do we need to make sure that particularly vulnerable populations like Aboriginal people, people in lower income areas, this is something Julie was touching on, does that matter? And how are we going to make sure, I know you're not a policymaker, but how do you think we should make sure that happens?
Thanks, Leslie. Yeah, that's absolutely critical. So this vaccine equity question of making sure everybody gets access to the vaccine and everyone gets to see the benefits of vaccination. Because if you get your 80% by, for example, only vaccinating one age group of people or only people in the cities, then you're leaving a whole load of people that the virus can really rip right through. So if you have any pocket that's under vaccinated, then COVID can transmit very quickly. And that's just thinking about transmission. There's obviously two different things that vaccinations do. Transmission, if we can reduce the numbers, that's great. But obviously one of the primary things is reducing those health impacts, direct impacts for people who catch COVID. And so absolutely we have, there's a huge problem in Australia and around the developed world of health inequalities. And it's kind of everything always cuts the same way. The socioeconomically disadvantaged people have less access to healthcare. They have more health problems, and they are more susceptible to, for example, misinformation about things like vaccination. So absolutely, that is critical. But obviously, the federal government has decided to produce overall headline figures of the types of things that everyone should aim for, to give everyone aspirations and to convince them to go and get vaccinated. But that's not to say that is the policy and nobody cares what's happening like under the hood and under the, at the kind of finer grained level. So getting those vaccines out to everyone is absolutely critical.
Okay. So Julie, how are we getting people vaccinated? Where are we in this journey? Are we doing well? When are we going to get there, essentially? Are we there yet? No, we're not there yet.
And Willie said, we're doing well. We've really cranked it up. Now we've got better supply, and there's even more Pfizer coming in, which will help a lot. We've seen a steeper rise in our vaccination uptake since late June, basically when Delta came to New South Wales, I think. And yet there are these disparities that have emerged already. So there are some areas which have coverage. So for example, the lowest coverage is in outback Western Australia in the north, where around 15% of people have had one dose. And one dose, by the way, is important because it shows willingness and ability to overcome barriers. And you compare that with Sydney's Baulkham Hills and Hawkesbury, and that coverage is for one dose. Actually, sorry, this is 2 doses, is over 40%. So 40% compared with 15%. So we've got some major gaps there in terms of areas. And what we need to do, I think, is to keep making sure that people have very good access to vaccination, particularly in areas where it's harder for people to access services using traditional means. They might not have a smartphone, they might not have the health literacy, the digital literacy, have drop-in clinics, have vaccination without a Medicare card required, just make it so convenient. What I find it very difficult to hear is my Aboriginal colleagues talking about their sister or brother who manages to overcome their hesitancy to have a vaccine. They go to a clinic and they're turned away because they haven't made an appointment. The services need to be so flexible. So access is an issue. And then, of course, the challenging topic of addressing ongoing concerns about vaccination and helping people navigate their concerns or mistrust or whatever it is that acts as a barrier as well.
And so where does the vaccine passport, and I might throw this to you, Norman, where does the vaccine passport fit into this world in which we need to maximize the number of people? Norman, you've spoken about 90%, so we need to get, about 90%, let's say somewhere between 80 and 90% of people vaccinated. So where does the vaccine passport fit into that? And how do we accommodate the people where we're seeing slower rates of uptake? How do we make sure that they're coming along?
Well, vaccine passports are not straightforward in any shape or form, and they can exaggerate the sort of inequities that Nick and Julie have been talking about. Exactly what you're saying is that some people have had the opportunity to get vaccinated and others, and then they get excluded. And there's probably the right time to bring them in is when you're sure So it's like opening up at 80%. And what Nick was talking about, and both Julie, about disadvantaged populations and populations who are not necessarily accessing mainstream media and information, is you've got to be sure that everybody's had the chance to be immunized, and you've done everything you possibly can in the terms that Julie, and it's really important to be listening to Julie, in the terms that Julie's been talking about: maximum convenience, get rid of every barrier, get out there, don't rely on just GPs, pharmacists, walk-in clinics, everything. When you reach that point, there probably is a tailing off. If you look internationally at around about 70-80%, it's a bit of a tailing off. And you probably need other extra motivations to get to become vaccinated. And a vaccine passport is one way of doing that, is that you only get access to the benefits of life, such as travel, getting on a plane, going to a bar, going to a restaurant. You only get access to that. That's one aspect of it. The other aspect of it is safety, which is you do have a 50% reduction in the risk of being infected and therefore pass it on to others. And therefore it's part of that population benefit, but it's not a guarantee.
If you're vaccinated, in other words, if you're vaccinated.
Yeah, you might have a vaccine passport, you're okay, but you might still be carrying the virus. So it's not a guarantee of safety there, but it does mean that you've got a group of people who are less likely to be passing it on. And you're probably still going to have social distancing, better ventilation, exactly what Nick was talking about, mask wearing indoors in public spaces, all those things going on until we get to much higher levels. But it's a tool. And primarily, and it's also a tool to allow you to travel. You're not going to be able to get on a plane overseas. When you land in Italy or other countries, you're not going to be able to go to a bar unless you've got a vaccine passport. It opens up the world to you. So there's multiple things going on with a vaccine passport. You just got to be really careful about not introducing it too early. I don't know what Julie thinks about that.
Yeah, I mean, go ahead, Leslie, sorry.
No, go right ahead, Julie. What do you think about that?
I agree, Norman. You have to have it has to be well justified, enough disease burden in that particular setting, like an aeroplane, that you've also explored other options for protecting people. There's some people who will always never vaccinate. So at a policy level, we still have to plan for those people. And if we have a situation indefinitely where those people can't travel interstate, can't travel overseas to see family members, can't visit family members in aged care, cannot go to the cinema, we end up with, it is a problem for those people. So I think because passports are essentially a form of coercion, they're a stronger policy lever and therefore need to be well justified. You need to be confident that requiring vaccination gets you extra coverage over and above what all the other measures give you, such that it really does reduce disease risk meaningfully. And they are well justified at the moment in healthcare, where healthcare workers, we don't want them to be passing COVID on to others, particularly in this environment where so many people are unprotected. But in situations like interstate travel, it might be sufficient to have mandatory documentation rather than mandatory vaccination, documentation of protection. In other words, a sound recent negative test, evidence of previous infection, evidence of vaccination, or a medical exemption.
Right. And Nick, I know that you wanted to talk about the vaccine passports.
Wasn't so much about the vaccine passports, but I just wanted to add in something positive about this, which is that we are vaccinating at an incredible rate, as Julie said. And so it's been getting faster and faster. And if you look at kind of the national numbers, we recently passed the threshold of vaccinating about 1% of the population every day, which is faster than the UK or the US has ever achieved in their rollouts. And that's the whole population. In some parts of Australia, so particularly in New South Wales, where they've had a real push, it's been much, much higher than that. So it's going at an incredible rate. And unlike other countries which decided to open everything up at around about the 60% coverage mark and then basically throw away all the restrictions, I think I'm pretty confident that we can get to at least this 80% mark. And I think everyone sees the benefit of getting at least to that point. It's hard to think that conversations are around, can we get this even higher? Because
we will.
We will, yeah, absolutely. It's really impressive, everyone's appetite to get vaccinated. And, you know, we're talking about the vaccine passports are for letting people who, you know, are vaccinated have more freedoms, as opposed to in other countries, you know, where they've kind of given everyone freedoms, but too early and everything's going a little bit wrong in terms of transmission. They're talking about essentially imposing new restrictions on people who aren't vaccinated. So there's definitely a much more kind of positive message there, but we're doing a fantastic job. And we've seen in other countries that, you know, so Iceland in particular recently got to, I think, 80% double dose vaccination coverage. And people say they'd be keen to do that in Australia. And to be honest, Australia is one of the countries with the highest vaccine acceptance in the world. So it's looking positive, and I think we can get some really high numbers. Only if everybody goes out and rolls up the run.
I suggest we're not having supply issues anymore, because I remember, and I'm not going to be able to quote him directly, but I remember the Premier of Victoria saying something like, if he had the supply, he would, you know, line everybody up at the MCG and get it done in 3 days or something. It was something of that kind of nature. So are we no longer in a position where we're being constrained by supply?
We are with Pfizer still, I think. Would you agree, Nick? But not AstraZeneca.
That's absolutely right. There's loads and loads of AstraZeneca, and it's not being used, and it's produced, and it's there to go. Certainly in a lot of states. So in Victoria, a lot of friends of mine who are in the kind of the Pfizer age group are opting to get AstraZeneca because they know it's important to get vaccinated and to do it soon. And they've, you know, that's their personal choice. That's, you know, not health advice, but that's, you know, they're really keen to do that because they know that they can go out and they can get vaccinated with that now. But there's definitely still a supply issue with Pfizer. It's getting faster, more doses are coming in, so hopefully that will ease up soon as well. But using up those AstraZeneca doses, is the best thing we can really do to speed up vaccination.
And Norman,
anyone, just to correct that, anyone can have, it's health advice that you can have AstraZeneca. It's just that you need to be aware of the risks of TTS and be informed of those, like any vaccine, I guess. Yeah.
Yeah. So Norman, do you want to just quickly go over why it's a good choice to make to have the vaccine that's available to you now, which is, as what we've heard, is, and depending on where people are, if they can't get Pfizer, they certainly should be able to get an AstraZeneca shot tomorrow.
Well, if you're over 60, sounds negative, but if you're over 60 years old and you're hanging out for Pfizer, you'll be in a queue behind 12-year-olds. So do you actually want to be waiting till 2022 to have your vaccine? And there's still some people in that age group hanging out, although it's getting much better than it was. So, you're getting up to 70 or 80% of people having had the first dose in that age group. So they're listening and they're getting it done. So here's the statistic. If you catch COVID-19, you've got a 1 in 10 chance of ending up in hospital, a 1 in 50 chance of ending up in ICU. And depending on your age, there's an average death rate of 1.7%. So that's 1 in 100, 1 or 2 people in 100. Yes, the older you are, the more likely it is, and that becomes rarer as you get younger, but that's the average, is 2 in 100. So the risks of the serious side effects of both Pfizer, or relatively serious side effects. So if you are, say, 30, the risks of that clotting syndrome that Julie talked about 1 in 30,000, 1 in 30,000. And your risk of dying is about 1 in a million, versus 1 in 10 being in hospital, 1 in 50 ending up in ICU. And if you end up in ICU and on a ventilator, your outcome is not good. And if you get COVID-19 as an adult, you've got maybe a 30% chance of prolonged symptoms lasting more than a month and sometimes up to several months, versus those rare side effects. And that's why you get immunized, and you get immunized quickly with 2 doses, so you're covered.
Yeah, thank you.
And by the way, Pfizer has a side effect as well, which is inflammation of the heart, affecting younger people, mostly men, but that lasts 3 or 4 days. I'm not aware of anybody dying of that. You just get monitored closely and you get better. So the side effects are really, compared to the enormity of the pandemic, the side effects are really rare.
So, I mean, I think there's no question now that we have COVID, and that we're going to have COVID, because if I'm understanding it correctly, and all of you experts can jump in if I'm not, what's going to happen is, as we get to these figures, this 80% or this 90%, we're going to start traveling within Australia, and we're going to start leaving Australia and coming back, and people are going to start coming in, which means there is going to be COVID in not just New South Wales and Victoria, it's going to be around in general. And if you are not vaccinated, your risk of getting sick from COVID, from getting sick from it and dying from it, is significantly higher than any risk you would take with having a vaccine. That was a shot of that, wasn't it, Norman?
But the states might differ, Leslie, in terms of whether they're letting people in at the international border without the full hotel or other quarantine. I know WA is very risk averse, and that's understandable because they don't have COVID. I mean, Nick's over there in Perth living a perfectly normal life, while I'm here in Sydney.
We're trying not to hate him for it.
under a hard lockdown here in one of the hot spots in Sydney and Durham country. So, you know, the premiers will be different about what's an acceptable risk, and we may well find that international travel is easier for us in New South Wales and perhaps Victoria and maybe other states. And maybe WA will start to put the pressure on their premier by then, because they'll be seeing us all travelling overseas potentially. And they're not
things and roundabouts, huh? Look, I'm gonna wrap up the part where I ask you the questions, and I'm just gonna throw out a few of the questions that we've had from our audience that I couldn't quite kind of weave into the discussion. So anyone can put their hand up or just start talking in response to these. We've had somebody ask, is there room for flexibility during lockdown? For example, a religious gathering in an open field or drive-in? And what is the medical reason for curfews?
There's not good evidence to support curfews. There may be a little bit of a reduction. I mean, Nick can probably talk to this more, because I'm sure our modelers would be interested in their impact, because it's a potential measure. But it's probably a pragmatic measure for law enforcement, perhaps, and it might be a bit of lockdown theatre as well, to appease the pressuring journalists who aren't in a hotspot. Yeah, that's my input.
Okay. Anyone else on that?
I would agree with that. I mean, it's scraping the bottom of the barrel in terms of trying to squeeze out a transmission reduction. But, you know, there have been times, I guess, when people have been desperate to try and get cases down as quickly as possible. But as Julie was saying earlier, there could be so many perverse negative impacts from that, because curfews and things tend to target certain people more than others, and they just can ram home some inequalities there. But there's definitely a very valid question about what sorts of things should be put in place, what affects transmission but isn't too damaging to people in their lives. And it is a really difficult job to work out exactly what impact different things will have, weighing up different things. That's why we've seen about 100, 200 different rules come in the different states over time. Everyone's trying to optimize that, just to try and have it as relaxed as possible while still bringing the COVID down when we've had outbreaks. But it is a difficult thing, but I think people are doing their best job to try and generally have minimal policies.
And Leslie, a big shout out to the policy people who are working incredibly hard with the nuance of all these public health orders and trying to help communicate them to the public. It's a huge amount of work. It's often not seen.
Absolutely.
Sorry.
Which is why you go for simplicity.
Sorry, go ahead.
No, which is why you try and go for simplicity, but simplicity means you lose the nuance about, one of the reasons you pull kids out of school is actually to stop the parents circulating as much as stopping the infection in school. So, I mean, I think we've said what we need to say about lockdown. And you could have outdoor gatherings, religious gatherings. They would be low risk, but then there's the travel, there's the pinch points where you could communicate the virus. It's not entirely straightforward saying, yeah, outdoor is entirely safe, because there are points in outdoor activities where large numbers of people gather where you can spread the virus. So you've got to be really careful about some of those things.
We saw that at a sporting event, didn't we? Where there were.
It was it was the what used to be the Colonial Arena. I think that one of the gates, there was probably transmission.
Mm. Somebody else has asked, when we reach 80% vaccination, should we approach LGAs with low vaccination rates differently? So, and really there's the equivalent, question is how do we approach people or areas where we know the people aren't vaccinated, or we know the area has a low vaccination rate? Should we feel less safe? Is there anything we should do?
My view is we shouldn't open up into any degree at all unless those areas have been vaccinated to the same level as everywhere else. We're all in this together, and we should not have ghettos in our communities. And that's the danger at the moment, that people in southwestern Sydney, western suburbs of Sydney, feel as if they're in a ghetto, and so do people in the northwest corridor of Melbourne. And we should, as a society, say we're not going to do it unless we've all reached 80%. That's the yardstick, not Toorak, Armadale, Indooroopilly, Vaucluse and Double Bay, but everywhere.
But Norman, is that realistic? I mean, do you think our PM is going to say that now publicly?
No, I don't. I'm just giving my own opinion. but no, I don't think it's realistic. But we should be able to get up to reasonable levels where people can feel. The people in those suburbs need to feel safe as well. I mean, I think it's a really difficult dilemma, and and have we done everything we can to bring it up to high levels?
Yeah, I agree with you. But I just find it hard to imagine the PM saying that will be now the thing that he aims for.
Well, we can absolutely hope, and we can also hope that he takes the advice of all three of you and that he was tuning in tonight, although I suspect he wasn't. I'm going to need to wrap it up.
It's in the model that he's touting around the country. It's in there. So,
as a national average, but an average is mask variation, as you know. And that's the concern. There are going to be, particularly for Aboriginal and Torres Strait Islander communities, there's going to be inequities in access to protection.
So hopefully that will be addressed. I think everyone's spoken very eloquently about that tonight, and I would really doubt if anybody in our audience disagrees that we need to ensure that everyone in Australia has equal access and that we've all been able to vaccinate ourselves before we open up. So
can I just?
Yeah.
I know you're running out of time, but I just want to say one thing to reinforce something that Julie said earlier, because people from lots of different communities are watching this, who come from the communities which are struggling to get vaccinated. Is the way we get through this is through community leadership and actually community control. So Aboriginal communities are very strong on community control. They're not necessarily strong in getting the infrastructure they need from, such as housing and other things, from the federal government and others. But it is about community leaders taking charge of this situation and actually telling the policymakers what's needed in their communities, rather than policymakers coming in and telling them. So I think that if people watching this take more leadership, I'm not saying they're not taking leadership, but take forceful leadership, we will get there much faster than otherwise.
Okay. Thank you. That's a great way for us to end, Dr. Swan. Thank you so much. So I want to thank personally Julie Leask, Professor Julie Leask, Professor Nick Golding, and Norman Swan. I've really enjoyed speaking to all of you, and I think it's just been a fantastic conversation in which you've shared a lot of knowledge with the audience. So thank you so much for that. I'm just going to throw back to Amit so he can close us out.
Thank you, Leslie, and thank you to each and every one of you for sharing your wisdom, your insights, and your knowledge. And it's a great recommendation that Dr. Norman Swan finished off with. And it does require leadership from individuals and particularly community leaders. And I know that various communities have had private sessions, when I say private, community-focused sessions to go through some questions that the community members may have. So it's very important that collectively we are providing opportunities for more information to be spread out to those who may not be reading up on mainstream media. So again, thank you each and every one of you. I just wanted to quickly, before I wrap up, just say that we've also got another program on the 16th of September. It will be a webinar live streamed via YouTube on Thursday, the 16th of September. It's called Pandemic Prayer and Positivity. We'll have Archbishop Comensoli speaking with Associate Professor Salu Uja, talking about this particular issue and how we can remain optimistic and resilient through this period. And later on in September, with the amount of eyeballs looking on screens, we're looking at online safety. How do we protect particularly our children from harm that may come from online means? So we're looking at how we can provide measures in place and what kind of conversation you could have with your child as a parent about being mindful of which sites you go onto and how to be alert in the online arena. For more of that information, feel free to tune on into our website at the Australian Intercultural Society, www.intercultural.org.au. So thank you again to everyone. Thank you to everyone who has tuned in and watched this program. It will be up on this YouTube page for later viewing. So thank you again and have a great evening. Bye.